Game over. It is game over.
Game over, cancer.
I'm Val Solomon, Director of Program Impact at Cannonball Kids Cancer Foundation.
And I'm Dana Nichols, Executive Director of CKc.
Game Over, Cancer, a podcast dedicated to exploring conversations about pediatric cancer research, solutions, and inspiring family stories.
We're a nonprofit dedicated to creating innovative treatment options for kids fighting cancer and educating for change.
By creating a space for these conversations, we empower the community to take action and provide tangible hope.
Game over, cancer. Screw you, cancer.
Today's episode is all about consistency, the long game in pediatric cancer research. I think when we talk with our guests today, we get an idea of what optimism looks like in this world.
The longer I work here, the more I think like being an optimist has nothing to do with the amount of enthusiasm and energy you can put into any given statement or conversation. Like optimism is staying in this field when a breakthrough and progress is going to take 10 and 20 years and still believing at the end of each day that you're going to get there.
Yeah. Our guest today is facing and treating some of the most difficult and deadly cancers. He has also given back to CKc in so many different ways, and we're really excited to share this with you.
100%. Enjoy this episode. Well, our guest today has many titles, including professor, attending physician, Mosbacher Pediatrics Chair and Section Chief at the University of Texas MD Anderson Cancer Center in Houston. We know him as a CKc-funded researcher and the chair of our scientific advisory board. He's also our go-to representative for the scientific community. Anytime we have a question that we're in uncharted waters, we say, well, maybe we'll ask Dr. Friedman if this seems right. So today we welcome Dr. Gregory Friedman.
Yay!
Hello.
Thanks for joining us.
Hello. Thanks so much for having me on your podcast.
Oh, absolutely. As if we don't ask you to do enough, we have you come on and we'll talk for a bit. But we're really, really grateful. And we thought if you're open to it, we'll just start with, can you tell us and tell the audience about your research?
Sure. So my research is focused on what we call oncolytic viral therapy. So we use cold sore viruses, which have been altered to make them safe for normal cells, but deadly to cancer cells. And the virus infects and then kills the cancer cells and can spread to nearby cells. And then the virus also stimulates the child's own immune system to recognize and attack the tumor. So it has this dual attack. And most pediatric brain tumors are what we call immunologically cold tumors, meaning there are very few immune cells in the tumor to be able to recognize and attack the tumor. And that's why immunotherapies have traditionally failed in pediatric brain tumors. But by placing the virus directly in the tumor, we find that immune cells rush to the tumor to first remove the virus, and then those immune cells start to recognize the tumor as abnormal.
Wow.
So that's been the focus, and we've conducted some trials and continue to do laboratory research in this area.
It's so fascinating. Number one, when we tell people about your research, it's something I think, especially the way you've explained it now, the way we've heard you explain it in the past, that people, one, can understand. I think maybe understanding scientifically how viruses work. There's like a little bit more of, experience, I guess, for the common person to understand what that immune response might look like or be like. But what we often hear people say is, that is so cool. Like that's just like the response. But I mean, and it is very cool. So tell us, where did that come from? How did you?
Yeah, how do we get here?
How do we get to that part of your research?
It's a long line of individuals before me that discovered that viruses could kill, in addition to killing normal cells, they can actually kill cancer cells. And so I previously, before at MD Anderson, I was at UAB, and there are some individuals there, including Rich Whitley and Yancey Gillespie and James Markert, who had worked on herpes virus and understanding that there's certain genes in the virus that could be removed to make it so that the normal cells could prevent the infection. But when you remove those genes, you can still, the cancer cells aren't protected from the virus. And so they sort of recognized that. And then when I was finishing up my residency, starting fellowship, I heard about this research and contacted them and got involved. They had no thoughts of moving it in a pediatric direction. That was what I was interested in, and so that's how it sort of started and moved forward from there, of bringing this to pediatrics and then working on developing new and improved viruses that do even a better job of bringing in immune cells and killing tumors.
You do a great job of, bringing it down to a very palatable level of understanding, right? So quickly. But if you're sitting with a family and it's the first time they're hearing things like oncolytic viruses and immunotherapy, I mean, that can be overwhelming. What do you hope that they can understand, or what's the information that needs to get out there more for these types of approaches?
That's a good question. I think, we try to convey the fact that these have been altered in a way to make them safe for normal cells. There were several trials of these in adults, and now we've completed the first trial in children and find that they're thus far been very safe. And so, really now the approach is trying to make them even better at bringing in that immune response, but just explaining to them very simply, look, the virus itself can kill the bad tumor cells, but what seems to be even more important is that it stimulates that immune response, because if we can get the child's own immune system fighting against that cancer, then that's really gives us the best chance of getting rid of it. We know these viruses don't stay around forever. In fact, the immune system will come in and remove that virus. And so what happens, though, is that the virus breaks open the tumor cells, and now there's these cancer proteins that are exposed to the immune cells. And those immune cells now can recognize those tumor proteins as abnormal, because that's part of the problem in tumors in general, is that the immune system has not recognized them. We think that people get various cancer cells all the time and throughout your life, but that your immune system recognizes that there's a problem in those cells and removes them. And tumors then progress and become large tumors. The issue there is that the immune system's not able to recognize it and remove the tumor. So we're trying to sort of reteach the immune system that this is not supposed to be there, and that by putting a virus that the body recognizes very quickly not supposed to be there, that's how we can trigger that response. So we try to just explain that as clear as we can to the families.
Yeah.
That's so cool.
Yeah.
Putting a big flashing neon sign in and around the tumor that says, it's attack this.
Yeah.
This is not good. What are some of the outcomes that you all have seen kids and families experience as a result of the research that you're conducting?
So we completed the first, and I mentioned again, this is called oncolytic viral therapy. So we completed the first oncolytic viral therapy trial in children with a type of brain tumor called a high-grade glioma, and found that the virus was safe. We saw very mild side effects related to it that all were resolved on their own without having to do anything about it. And then we saw preliminary efficacy. So we saw signs of immune cells in the tumors after the treatment. We saw changes suggesting responses on MRIs. And then we saw a preliminary doubling of survival compared to what we know historically for this terrible disease. Survival at recurrence is less than 6 months. And at least in the 12 children we treated, the median overall survival was over 12 months. But it's only 12 children. And so what's important is to really confirm those results in a larger study. So now we are embarking on a phase 2 study, which is really focused on looking at efficacy further. And then we also have a trial of the the virus, a phase 1 trial, in a different area of the brain, in the back of the brain or cerebellum. And that's because we found with some of our lab studies that the tumors that tend to grow there, like medulloblastoma, appear to be even more sensitive to the killing effect of the virus. And so that's led to that trial. And then we have a second generation virus that I mentioned, Dr. James Marker. So this virus was developed. He's a close collaborator, and this was while I was at UAB. This virus has a human gene inserted into it that while it replicates, it produces a substance called interleukin 12, which is a powerful attractant for immune cells. So the idea is this virus does the same thing. It infects, it kills the cells, breaks it open, but it also produces that substance to bring in even more immune cells. So we hope to create an even more robust immune response. And we're about to open the first trial of this virus in children and adults with a very deadly tumor type called diffuse midline glioma.
Oh my gosh. I get chills. I get chills. It's so cool.
It's incredible work you do and talking about so many different trials that are starting. But can you take us back to a moment when you had a discovery in the lab that all of this work that has stemmed out from here had real possibility for your patients?
Sure. So when I first started, we were looking at my goal was to move it in a pediatric direction. And so we obtained a bunch of different pediatric tumor models, and we tested the sensitivity of all these different types of pediatric brain tumors, because before all they were testing on was adult high-grade gliomas, and we had a bunch of the adult high-grade glioma models too, as well. Well, we were comparing the sensitivity, and we find the pediatric tumors were much more sensitive to the killing effect by the virus. So they tend, the virus gets into the cells through different receptors, and those receptors tend to be more highly expressed on the pediatric tumors. So when we saw that, we thought, that's interesting, and it suggested that these tumors are going to be more sensitive to the killing effect. And then we also know that children tend to have more tend to be less immunosuppressed. They tend to have better immune systems than adults that are 60 years old with high-grade glioma. And so the hope we had was that these patients would mount a bigger response to the virus than the adult trials that had already been conducted. And that's essentially what we found, is that the tumors appeared to be more sensitive, and we tended to get bigger responses than what was seen in the adults. The adults saw responses as well, but it seems that children may be the ideal candidates for this type of therapy.
It's incredible.
Yeah, it's just one of the examples that we talk about a lot, which is kids need specific treatments for their types of cancer because the cancers are different. Even there's different pieces to understanding that cancer and how it functions in the body than even when they have it's the same kind of tumor with adults as well. I wonder if you could talk a little bit about, I know that, well, first I think we should mention we have worked a long time with the Kesslers, who have started a nonprofit called Trailblazers for Kids, and their son Jake was one of your patients. And I wondered if you had just a little bit of time to talk about, your relationship with them and how funding with CKc and Trailblazers has impacted your work.
Sure. So when we take care of these families and patients that come, especially, many come from far away. That was an example with the Kesslers, to take a chance. At that time, I was at UAB, so they came to Birmingham, Alabama, from up north, and I think at the time, people hearing, "Oh, you're going for this type of therapy," and I think it sometimes seems risky for these families. They have to uproot themselves for 3-4 weeks to come down and do that. So we develop a really close relationship with the families. And certainly Jake was an amazing young man who was really inspirational and I mean, never complained about anything. And, seemingly had a nice response to the therapy, which was great. Uh, and so, I think the family really appreciated the fact that they felt like this therapy and the relationships we formed, he ultimately, they felt like this extended the time they had and wanted to, uh, one of the things Jake wanted to do was raise money for cancer research. And so that became a passion of the Kesslers to develop trailblazers, because one of the areas that's a little bit lacking in funding childhood cancer research is the trials. There's a lot of foundations that focus on the lab and the bench research, but the actual clinical trials and moving forward, which is what Cannonball Kids does so well, there's not as many foundations. And so that was where Trailblazers came out of that. And then he, through Cannonball Kids and Trailblazers, ended up funding this second trial that I mentioned that's in the cerebellum and going after tumors like medulloblastoma.
It's incredible to take a family's individual experience and know that it was so important to the kids, important to Jake, and like what we're able to do and keep pushing forward and keep legacy in some way, I know is very important to me. And I think for you, I can't even imagine the implication of having worked with these individuals, these kids, and then continuing to do the work and fundraised in their names. And it's just like a really beautiful continuation of life and legacy in that way.
Yeah, these kids are pioneers in helping to develop new therapies for not only themselves but for future children. And we learn as much as we can from these trials and then take that information back to the bench, back to the lab, to make it even better. And now we're working on combination approaches based on what we learned. How do these tumors tend to overcome the virus over time? What can we do to prevent that? What sort of combinations will make the immune response even greater? And then we're going to take those back to the clinical trials until we get more durable responses. We had nice responses. I mean, we had 5 of the 12 children we treated lived at least 18 months or more, which again, median survival that's longer than the expected survival of newly diagnosed patients. And less than 6 months is the average. So we felt like we were making progress, but of course, until we are curing these children, we have a lot more work to do.
Yeah, absolutely.
Well, we mentioned a little bit, thank you for all of that. We mentioned a little bit earlier at the top, we were talking about the fact that you are on our scientific advisory board and you are in fact the chair. And I wondered if you could, in your words, tell our audience, we've talked a little bit about scientific advisory boards, but if you could share the function of a scientific advisory board for a foundation like ours, that would be awesome to hear your words on it.
Okay, so the scientific advisory boards are a group of experts in the area of childhood cancers who most of them are conducting their own research. And then the way this works is that when applications come in for grant funding to Cannonball Kids, these need to be reviewed and we need to pick out the strongest applications. And so that's the function of the scientific advisory board. It was created, I think, back in 2017 originally. I think back at its inception of Cannonball Kids, Melissa Wiggins, who's one of the founders, would reach out to potential grant recipients, which she did to me. I think I was the second one she reached out and would meet them in person and learn about the research and then see the hospital. Well, that worked for a while, but as Cannonball Kids Cancer Foundation continued to grow, that was not going to be possible anymore. And so the Scientific Advisory Board was formed. And I think around 2019, then we switched to a call for grants and more formal review process. And I think there were maybe 5 members of the Scientific Advisory Board. It was being led by Ted Johnson at Augusta University at that time, who was the first recipient of a Cannonball Kids grant. And then the growth of the foundation has just been tremendous now. And because of the number of applications we receive, we now have a letter of intent stage, which is where it's just a shorter application of the concept, and that's reviewed. And then the top half or so of applications are chosen to move on to the full application review. And then these experts that are a part of the Scientific Advisory Board, which I now think is up to 18 members. So we grew from just a couple to now 18 because we have so many applications, strong applications to review. And then those applications get scored by several members, and then we come together as a group and we look at the top scoring applications and talk about them and review the pros and the cons. And then we provide Cannonball Kids with, these are the applications that we think are the top when it comes to clinical trials, and these are the top for the young investigator grants. And then Cannonball Kids takes that information to make funding decisions.
I think it's so important because when people come to me, this is always my example, is I'm not a brain surgeon.
Right.
I'm not an oncologist. I'm not all of these things. So when someone comes to me to say, this is how I think we're going to cure this type of cancer, I think that sounds really good.
Yeah.
And I think it's not even as simple as, yes, that's going to work, or no, it's not, because we don't know that answer, right? But what I always find the most valuable from you and from the SAB is, okay, well, this is actually going to go into practice in a year. This is going to be 5 years before it hits bedside. And those types of details are what I truly could never see when I'm reading an application. And I think what's so important there is being able to be getting money out the door to the research that can give kids options the quickest. That's our mission. And so I think there's so much that goes into the science that just as an everyday human, I'm never going to be able to see. And I think that is such a valuable, deep piece of the SAB in itself, of us all working together.
Yeah, we have experts in all the different areas of tumor types. So like I know the brain tumors very well, but not is comfortable on the science on the leukemia or lymphomas, but we have experts in that area. We have experts in solid tumors outside the brain. And so, and when we're looking at these grants, of course, we know the mission of Cannonball Kids. And so that always plays into our decision making, but we're looking at feasibility of the trial. Can this get done? Do they, will they be able to accrue the number of patients they need to get meaningful answers on safety or efficacy? And so it's a real team approach to identify the most promising applications and the most promising research to move forward. And like you said, we don't always know, right? We're using the background, all the information that we have based on the therapy and based on what their plans are, and then we make the best decisions to push those things forward. And the nice part about the Scientific Advisory Board, we also try to provide all the applicants with some feedback on, here's some areas that we think you could improve the application on for next time, whether they decide to come back and apply again or somewhere else. At least that information can be helpful, and that these were the areas that we think that you could strengthen your application so that hopefully that's useful for them to move forward and ultimately get funding for their ideas, because there's so many good ideas. I wish we could fund more of them, as I know you do.
Me too.
Yeah. It's such an important part. I'm so glad we're talking about this, because I think what we're discussing right now is CKC's, like, our value proposition to the world, right? Like, when we say invest in CKc, we're saying we're putting the money into these really important but effective, in as quickly as we can,
Yes.
projects. And the scientific advisory board is how we determine as an organization what those are. So, and by the way, volunteers, all of them are volunteering their time. So we've gone from 5 to 18 people spending hours and hours, not just, reading these projects, but probably doing their own, like, investigating, maybe emailing on the side. Hey, what do you think about something? Like, conferring with their groups as well about the feasibility or, the environment for a project like this. And so a lot of unseen work. And am I right in assuming that this is not the only scientific advisory board you're sitting on? Or I just imagine everybody coming to our meeting and then logging out and then getting on another one.
Yeah, so most of these individuals, these are, we have a scientific advisory board of leaders in the field, and so they get asked to review for multiple other foundations, and also then the NIH sometimes, and the Department of War they have their own grants, and so they will also ask. And so it ends out sometimes it's you're moving from one grant review panel to another.
I can imagine. I think that that's something too that we think about as an organization. There are a few different ways that we have tried to make it especially more manageable for folks who this is going to be a volunteer role, and it's very obviously like a foundation of what we do, that if we can partner with an organization like Trailblazers, where, that maybe if they are following the recommendations of our scientific advisory board as well, that means there's one less that you have to sit on. But also, what are the things that we could do about our process that would make reviewing grants easier? And like constantly trying to, listen to feedback from our advisory board and put that into practice to make things a little bit easier on everybody, I think, is definitely a goal for us too.
Yeah, 100%.
And there's, I will say though, as a reviewer, you do learn a lot when you review other applications. You learn about where the field is heading, and for some, you learn how to put together a stronger application for your own research. Certainly some of the very early foundations, and I also reviewed back years ago for the FDA, which funding some of these clinical trials through R01s. And because I sat on those, I learned what was going to be an effective grant. So, I think going to these panels, we've learned about how to write more effective grants, where things are headed, and maybe changing our research up, or moving in directions that we might not have originally moved in, because we're seeing, hey, this area seems to be working real well. Maybe we need to incorporate some of these types of combination approaches in our therapy. So I think there's there it's not just, yes, it is volunteer, but I think over time it makes you a better grant writer and helps you get funding for yourself. And then many of the scientific advisory board members have submitted applications to Cannonball Kids, ultimately received funding. And some of the early members were all ones who had received funding. So I do think, there's always benefits even on the review side.
Yeah.
That's great. We're always looking for partnerships where, CKC gets benefit, but also the partner gets a benefit from it as well.
Yeah, absolutely. Mutual benefit is lovely
Mhm.
for sure. Well, I think as we start to close out a little bit, if we are looking ahead, what are you hoping to see for the pediatric cancer field or in treatment over the next decade?
I think in terms of immunotherapies, I still think immunotherapies are the way forward. We can use all sorts of chemotherapies and radiation, and they have their role, but ultimately, a lot of toxicities associated with those. And not only do we want to reduce toxicities, but those therapies for a lot of the types of brain tumors we have are not effective or can lead to secondary malignancies, which is tragic. You cure the first malignancy, and then next thing you know, you have a secondary malignancy from the therapies you use to cure the first one. So I still think, if we can bring the immune system in to recognize the tumor, that's how we're going to get the durable cures of this disease. And so there's a lot of progress being made in the area. It's not just oncolytic viral therapy. There's the CAR T cells and vaccines. And ultimately, what I think is that it's going to be combination approaches. I doubt it's going to be one specific therapy alone is enough. The problem is, when we're first testing these, we're testing a lot of these in recurrent patients. They may be a little more immunosuppressed, and then we're typically just having to test one at a time. But where the field needs to move, in my opinion, is to combination approaches. So bringing some of these together, whether it's an oncolytic virus plus a vaccine plus a CAR T cell, using they can all work together. They can become. We find in the lab, at least, that many of these therapies are synergistic. They work very well together. They make each therapy better. And so I think over the next decade, what we're going to see is better combinations. Really moving the field forward and pushing survival further. Some of those therapies are more toxic than others, and so it's still going to be trying to design something that maintains quality of life, but also is much more targeted to the tumor itself. So I think that's where we're headed, and I expect continued improvements in survival in some of the most difficult cancers. We haven't had a lot of improvements over the last 30 years. We have to be honest about that. We've had very minimal benefits in a lot of different tumors, but I think we're on the cusp where we're understanding the immune system better. We're recognizing that they're the cells that are responsible for recognizing the tumor and attacking it, and also the cells that are sort of regulatory cells that are preventing the immune system from functioning. So you can kind of target both of those, right? You target the ones that are the attackers to make them more effective and to sustain that attack. And then you target the regulatory ones and try to release what their brakes that they're applying on the immune system. So I think we're getting closer to hopefully a golden age of immunotherapy where we're really seeing the breakthroughs that there's been so much promise in the field, but we're seeing there are patients that are having breakthroughs, but it's not universal yet. And we're getting much closer, I think. So 5-10 years down the road, which you were asking about, I think we're going to see a lot more of those breakthroughs and more durable responses in the patients that we're treating.
That's fantastic. I mean, that's what we talk about every day too. It's not going to be one day. It's going to be small steps every day, compounding to slowly improve. And then one day it'll feel like a magic, like it just happened.
Right.
But we'll all know that it was decades of work from lots of different researchers, and we're certainly so grateful for all the work that you do and for everything that you do for CKC, including this podcast.
Including take another hour of your time to be on our podcast. We're so grateful. Thank you for your time today. We appreciate you.
Happy to do it, and feel part of the Cannonball Kids family from years of support from Cannonball Kids, and so this I enjoy doing.
Well, awesome. Well, the reason CKC invests in innovative research is to make life and treatment easier for kids and their families to be able to fund research like Dr. Friedman's been talking about today. So if you are listening and want to support, you can make a gift on our website, cannonballkidscancer.org.
And we want to thank you for listening to Game Over Cancer. I think that there were a lot of really amazing nuggets that we talked about today. I would love for folks to share this podcast with this episode just with anybody who wants to learn a little bit more about some really, really cool research happening right now.
Absolutely. So thank you for tuning in. We appreciate you joining us and making a commitment to be part of our fight. I'm Dana Nichols.
I'm Val Solomon.
And until next time, we will see you later.
Join us as we transform fear into courage and turn adversity into opportunities for change.
If you want to be involved in the conversations that create change in the world of pediatric cancer, take a moment, share, like, and subscribe. Absolutely. Screw you, cancer. Get the heck out of here.